This is the continuation of cardiac dysrhythmia. In this video, we will cover junctional dysrhythmias. Junctional dysrhythmias start in the area of the AV node to the bundle of his known as the AV junction. If SA node does not fire or the signal is blocked, the junctional dysrhythmia occurs. When this occurs, the AV node becomes the pacemaker of the heart. The impulse from the AV node usually moves in a retrograde or backward fashion. This produces an abnormal P wave that occurs just before or after the QRS complex or is hidden in the QRS complex. The impulse usually moves normally through the ventricles. Junctional dysrhythmias originate within AV nodal tissue and may include premature junctional complexes, junction rhythms, nonparoxysmal junction tachycardia, AV nodal reentry tachycardia. Now let us see each one in detail. First one, premature junctional complex. A premature junctional complex is an impulse that starts in the AV nodal area before the next normal sinus impulses reaches the AV node. Premature junctional complexes are less common than PACs, that is, premature atrial complexes. The causes of premature junctional complexes are digitalis toxicity, heart failure, coronary artery diseases. The characteristics of premature junctional complexes are almost the same for PACs, except for the P wave and the PR interval. The P wave may be absent, may follow the QRS, or may occur before the QRS but with a PR interval of less than 0.12 seconds. This dysrhythmia rarely produces significant symptoms. Treatment for frequent premature junctional complexes is the same as for frequent PACs. Premature junctional contractions, also called atrioventricular junctional premature complexes or junctional extrasystole, are premature cardiac electrical impulses originating from the atrioventricular node of the heart or junction. This area is not the normal but only a secondary source of cardiac electrical impulse formation. These premature beats can be found occasionally in healthy people and more commonly in some pathologic conditions, typically in the case of drug cardiotoxicity, electrolyte imbalance, mitral valve surgery, and cold water immersion. If more than 2 such beats are seen, then the condition is termed as junctional rhythm. On the surface ECG, premature junctional contractions will appear as a normally shaped ventricular complex or QRS complex, not preceded by any atrial complex or P wave, or preceded by an abnormal P wave with a shorter PR interval. Rarely, the abnormal P wave can follow the QRS. Next, we will see junctional rhythm. Junctional rhythm or idionodal rhythm occurs when the AV node instead of sinus node becomes the pacemaker of the heart. When the sinus node slows from increased vagal tone or when the impulse cannot be conducted through the AV node because of complete heart block, the AV node automatically discharges an impulse. Characteristics of junctional rhythm not caused by complete heart block are ventricular and atrial rate. Ventricular rate is 40 to 60 beats per minute. Atrial rate will be 40 to 60 beats per minute if P waves are discernible. Ventricular and atrial rhythm is regular. QRS shape and duration usually normal but may be abnormal. P wave may be absent or after the QRS complex or before the QRS, may be inverted, especially in lead 2. If the P wave is in front of the QRS, the PR interval is less than 0.12 seconds. P is to QRS ratio will be 1:1 or 0:1. Junctional rhythm in lead 2, short PR intervals and inverted P wave are seen. Medical management of junctional rhythm may produce signs and symptoms of reduced cardiac output. If this occurs, the treatment is the same as for sinus bradycardia. 0.5 mg of atropine may be given rapidly as an IV bolus and repeated every 3 to 5 minutes until a maximum dosage of 3 mg is given. Atropine blocks vagal stimulation to the SA node and therefore accelerates heart rate. If atropine is not effective, emergency pacing may be needed. Now let us see non-paroxysmal junctional tachycardia. Junctional tachycardia is caused by enhanced automaticity in the junctional area, resulting in a rhythm similar to junctional rhythm, except at a rate of 70 to 120 beats per minute. Although this rhythm generally does not have any detrimental hemodynamic effect, it may indicate a serious underlying condition such as digitalis toxicity, myocardial ischemia, hypokalemia, or chronic obstructive pulmonary disease. Because junctional tachycardia is caused by increased automaticity, cardioversion is not an effective treatment. No treatment is usually indicated. Rhythm spontaneously resolves as the inciting event subsides. If the rhythm is hemodynamically disturbing, AV sequential pacing at a rate faster than the tachycardia may suppress the rhythm and restore the atrial contribution to cardiac output. This pacemaker can function as an atrial demand pacemaker or an AV sequential demand pacemaker or as a ventricular demand pacemaker if atrial pacing cannot be achieved. Now we will cover atrioventricular nodal reentry tachycardia. Atrioventricular nodal reentry tachycardia or AVNRT is a common dysrhythmia that occurs when an impulse is conducted to an area in the AV node that causes the impulse to be rerouted back into the same area over and over again at a very fast rate. Each time the impulse is conducted through this area, it is also conducted down into the ventricle, causing a fast ventricular rate. AVNRT that has an abrupt onset and an abrupt cessation with a QRS of normal duration has frequently been called paroxysmal atrial tachycardia. AVNRT also occurs when the duration of the QRS complex is 0.12 seconds or greater and a block in the bundle branch is known to be present. This dysrhythmia may last for seconds or several hours. Factors associated with the development of AVNRT include caffeine, nicotine, hypoxemia, and stress. Underlying pathologies include coronary artery disease and cardiomyopathy. However, it occurs more often in females and not in association with underlying structural heart disease. AVNRT has the following characteristics. Ventricular and atrial rate. The atrial rate will be usually 150 to 250 beats per minute. Ventricular rate usually 120 to 200 beats per minute. Ventricular and atrial rhythm will be usually irregular. Sudden onset and termination of the tachycardia may be present. QRS shape and duration is normal but may be abnormal. Usually very difficult to discern P wave. If the P wave is in front of the QRS, the PR interval is less than 0.12 seconds. P is to QRS ratio is 1:1 or 2:1. The clinical symptoms vary with the rate and duration of tachycardia and the patient's underlying condition. The tachycardia usually is of a short duration, resulting only in palpitations. A fast rate may also reduce cardiac output, resulting in significant signs and symptoms such as restlessness, chest pain, shortness of breath, pallor, hypotension, and loss of consciousness. Now, let us see the medical management of AVNRT. Because AVNRT is generally a benign dysrhythmia, the goal of medical management is to alleviate symptoms and improve quality of life. Patients who become significantly symptomatic and require emergency department visits to terminate the rhythm may want to initiate therapy immediately. However, those with minimum symptoms with an AVNRT that terminates spontaneously or with minimal treatment may choose just to be monitored and self-treat. The aim of therapy is to break the re-entry of the impulse. Catheter ablation is the initial treatment of choice and is used to eliminate the area that permits the rerouting of the impulse that causes the tachycardia. Catheter ablation is a treatment for abnormal heart rhythms that uses heat or cold to destroy the faulty tissue. Vagal maneuvers may be used to interrupt AVNRT. These techniques may increase parasympathetic stimulation, causing slower conduction through the AV node and blocking the re-entry of the rerouted impulse. Vagal maneuvers are a set of techniques used to stimulate the vagus nerve and modulate the electrical activity of the heart. These maneuvers aim to slow down the electrical conduction through the atrioventricular node, interrupt the reentry circuits responsible for SVTs, and restore normal sinus rhythm. Some patients use some of these methods to terminate the episode of their own. Because of the risk of a cerebral embolic event, carotid sinus massage, which may be performed by physicians, is contraindicated in patients with carotid artery disease. If the vagal maneuvers are ineffective, the patient may then receive a bolus of adenosine to correct the rhythm. This is nearly 100% effective in terminating AVNRT. Because the effect of adenosine is so short, AVNRT may recur. The first dose may be followed with a larger dose or with a calcium channel blocker such as verapamil, followed by 1 or 2 additional boluses. If the patient is unstable or does not respond to the medications, electrical cardioversion is the treatment of choice. The patient who is unstable may be given adenosine while preparations for cardioversion are being made. For recurrent sustained AVNRT, treatment with calcium channel blockers such as verapamil and diltiazem, Class 1A antiarrhythmic agents such as procainamide and disopyramide, Class 1C antiarrhythmic agents such as frecanide and propafenone, and Class 3 agents such as sotalol and amiodarone may prevent the recurrence. If the rhythm is infrequent and there is no underlying cardiac structural disorder, a single oral dose of frecanide or a combination of diltiazem and propranolol during an episode of tachycardia may be effective. If P waves cannot be identified, the rhythm may be called supraventricular tachycardia or paroxysmal supraventricular tachycardia if it has an abrupt onset until the underlying rhythm and resultant diagnosis is determined. SVT and PSVT indicate only that the rhythm is not VT. SVT could be atrial fibrillation, atrial flutter, or AVNRT, among others. Vagal maneuvers and adenosine may be used to convert the rhythm or at least a slow conduction in the AV node to allow visualization of the P waves. If the ECG does not assist in the differentiation of the dysarrhythmia, EP studies may be necessary to make the diagnosis.